Hello, good morning. I want to thank the organization committee of the Neurodiab Summer School for my invitation to participate in this virtual meeting, and also convey that for me it is a pleasure to share with all of you my presentation about the diagnosis of phenotype in diabetic neuropathy for an effective treatment. On the next slide is the possibility of prevention, protecting diabetic foot wounds can be based on an early and effective diagnosis of diabetic neuropathy phenotype. In order to address the diagnosis of phenotype of neuropathy, it is necessary to make a quick review of diabetic neuropathy. Usually diabetic foot diagnosis arrive late, and as you can see, it's an underdiagnosis, and the prevalence is about 28 to 40% of these patients. The next slide shows the study of Herman and Kennedy about diagnosis of diabetic neuropathy. That is insufficient, as we show in this slide, and also with high number of wrong diagnoses in specialists of diabetic neuropathy. Non-endocrinologists is near in the same exit of diagnosis of this kind of patients. Well, this is my first question about the last slides. Is diabetic foot under diagnosis, and what is the prevalence about that?
Okay, so we invite the audience to choose the response from the poll that they consider it's correct. And we will give them about 20 seconds to do so. And let's just check to see. So we have about 38% overdiagnosis, and overdiagnosis now has 44%, and underdiagnosis has 33%.
Okay, I continue. This slide shows pathophysiology of painless and painful diabetic neuropathy. Diabetes leads to several pathological changes in neuronal and vascular cells that can lead to structural and functional alterations of the neural system that can result in diabetic neuropathy. And here we can see in the red area risk factors for development of painful diabetic neuropathy, especially in this case. The selection of structural and functional alterations in diabetic neuropathy is important to remark the advances glycation end products, reactive oxygen species, and other more, as you can see in this slide. Diabetic neuropathy not only affects the axon of the nerve fibers, it also includes different sensory receptors, the posterior horn of the central nervous system, the blood vessels of the perineurium and intenarium, as well as the interstitial tissue that surrounds of the nerves. In this slide, I would like to show the most important aspect of the sensory polyneuropathy, and the typical or atypical divided in the Toronto consensus of Neurodiab. This kind of alteration, polyneuropathy, is a prevalence in the context of the diabetic neuropathy. And this is the consensus of definition of diabetic polyneuropathy. But I would like to remark, in the absence of symptoms, should not be assumed the absence of signs. This is very important. And What about the consensus for establishing the clinical diagnosis in polyneuropathy? Should be at least 2 positive tests to do it. The evidence that generalized variety can be further classified into at least 2 major subgroups. The typical polyneuropathy is a chronic, symmetrical, link-dependent sensory motor polyneuropathy. And it's thought to be the most common variety. And the other one is the atypical diabetic polyneuropathy, and are different from diabetic polyneuropathy sensory motor in several important features. Its onset, the course, manifestations, associations, and positive mechanisms. Here you can see 2 different pictures about the clinical picture of the atypical diabetic and typical diabetic polyneuropathy. The typical onset of symptoms may be acute, subacute, or chronic, but the course is usually monophasic or fluctuation over time. Pain and autonomic symptoms are typical features, and altered immunity has been suggested. It's only suggested. Typical diabetic sensory motor is a symmetrical, length-dependent sensory motor polyneuropathy, and are normally of nerve conduction test, which is frequently subclinical, appears to be the first objective quantitative indication of this condition. Remember that other causes of sensory motor polyneuropathy need to be excluded. This slide is only to show consensus about degrees of severity of diabetes sensory motor polyneuropathy. It's not possible to use every time in the clinical practice, but it's necessary to get it a practice to do it, because it's important to make a level of the alterations to know the evolution of this kind of patient. Here you can see the diabetic sensory polyneuropathy with the 2 possible situations. The present symptoms or signs of diabetic sensory polyneuropathy may include the following symptoms: decreased sensations, positive neuropathic sensory symptoms, as sleep numbness, prickling, stabbing, burning, or itching pain, predominant in the toes, in the legs, or in the feet, or seeing symmetric decrease of distal sensation, or inequivocal decrease or absent ankle reflexes. And the second is the probable. And the probable is the presence of a combination of symptoms and signs of neuropathy, include any 2 or more of the following: neuropathic symptoms and decreased distal sensation, or absent ankle reflex. The other one is the confirming. The presence of an abnormality of nerve conduction and a symptom or symptoms or a sign or signs of neuropathy confirm diabetic sensory motor polyneuropathy. If nerve conduction is normal, a valid measure of small fiber neuropathy may be used as UST or skin biopsy. Subclinical diabetic sensory neuropathy, the presence of no signs or symptoms of neuropathy are confined with abnormal nerve conduction or valid measures or a small fiber of the small fiber nerves. This is my next question. According to the Toronto Neurodiab consensus, how many types of altered nerve fibers are necessary to detect for the diagnosis of probable diabetic neuropathy?
Okay, so the question is in the pool area in the right side of the live session, and we will wait about 20-30 seconds to see the results. Right about now, 75%, only one nerve fiber is enough. But right now, 50%, 2 or more nerve fibers.
Right. Excellent. Okay. The next commentary is about the questionnaires. Questionnaires is important, the quality of life, because improvement should also be assessed, preferably using a validate neuropathy specific scale such as neurocall. But it's important in the file to put it a quality of life. Here you can see the severity of pain can be reliably assessed by the visual analog scale, which is the oldest and best validate measure, or the numerical written scale, and the 11-point Likert scale, which has been most widely used in neuropathic pain studies. About monofilament is a useful tool, but arrived too later to detect neuropathy or polyneuropathy in these patients. To assess for the severity of diabetic neuropathy, several approaches can be recommended. The graded approach online about various continuous measures of SUM scores or signals, symptoms, or nerve test scores. Scores of function, of acts of daily living, or of predominant predetermined task of disability. Irrespective of which approach is used, it is necessary to ensure good performance of evaluation with monitoring proficiency. Also, it is necessary to include a skin patch biopsy, a minimal invasive procedure, as Professor Gibbon talked this morning, allow morphometric quantification of intraepidermal nerve fibers. This slide shows all different QST, quantitative sensory testing device, to evaluate functional subtypes of large and small sensory nerve fibers. The vast majority only detect the dysfunction of large or medium nerve fibers for the vibration threshold, and only case 4 NERJEC and TS2 analyzer quantify the injury of the small nerve fibers, which do allow identifying the phenotype of polyneuropathy. We can divide the clinical diagnosis with the tools of the structural diagnosis, as we can use the confocal corneal microscopy or the punch biopsy. And on the other hand, we have the functional test to know what's about the alterations in the median on small nerve fibers. In diabetic patients with these kind of tools, we can graduate the lesion in the small nerve fibers as possible when the presence of length-dependent symptoms are or clinical signs of a small fiber damage, probable if the presence of length-dependent symptoms, clinical signs of small fiber damage, and normal serial conduction studies. And definitive, the presence of length-dependent symptoms, clinical signs of small fiber damage, normal serial nerve conduction study, and altered skin biopsy density and the ankle, and or abnormal quantitative sensory testing thermal threshold at the foot. Diabetic neuropathy is not treated properly. Here you can see the prevalence is 16%, about 16-25%, but 12% do not report symptoms, and more than 39% not receive treatment. This is the situation today of this kind of patients with diabetic polyneuropathy with painful. After nerve injury, maladaptive changes can occur in injury sensory neurons. and along the entry nociceptor pathway with the central nervous system, which may lead to spontaneous pain or pain hypersensitive. The resulting neuropathic pain syndrome presents as a complex combination of negative and positive symptoms, which vary enormously from individual to individual. This variation depends on a diversity of underlying pathophysiological changes resulting from the convergence of etiological, genotype, environmental factors, and the pain phenotype can serve, therefore, as a window on underlying pathophysiological neural mechanisms and as a guide for development personally pain medicine, maybe. What about the QST and small nerve fibers according to the Toronto Consensus of Neurodiab? In diabetic patients, to grade small nerve fibers at definitive diagnosis, the presence of length-dependent symptoms, clinical signs of small fiber damage, normal serial nerve conduction study, and altered the skin biopsy density nerve fibers at the ankle, and or abnormal quantitative sensory testing thermal threshold at the foot. This is the recommendations about QST of the Neurodiab, American Diabetes Association, and Neurolab. It should be noted, however, that even in more or less asymptomatic periods, the underlying pathogenetic disease process may be ongoing. By definition, neuropathic pain involves damage to the nervous system. Often, negative symptoms are the first indication of damage to the somatosensory system and can be detected mainly by quantitative sensory testing and story questionnaire. These two are important in the next slide to see what about these tests to make the study of the phenotype. This is the NLPC consensus about QST. It is based on a measurement of a response to calibrate, grade innocuous or noxious stimulus and represent in most respects an extension of the routine bedside clinical examination of the sensory system. My third question is, what is the diagnostic methodology used to detect the different phenotypes of painful diabetic neuropathy? The monofilament, the reflex hammer, and the questionnaire. Second, the quantitative sensory testing and questionnaire. And third, electroneurography and monofilament.
Okay, so we are expecting the audience to share the answer. Okay, so right now, about 80% the quantitative sensory testing, QST, and questionnaire.
This is the right response.
Perfect.
At this point, we can see the sensory neuropathy is highly complex diagnosis objective. So you can see the different small nerve fibers or large nerve fibers in the receptor to a scale of code to pain in the horn in the central nervous system. This is a high complex diagnosis objective. And what about the nociceptive pain? That reflects our capacity to detect the presence of potential damaging stimulus. This essential early warning mechanism. This sensation is mediated in the peripheral by high threshold primary sensory nerves. The nociceptors, which transmit information by nociceptive pathways, is the spinal cord to the brain. Neuropathic pain. The nervous system itself is injured and changes in its sensitivity can become persistent. Pain can occur spontaneously. Its threshold may fall dramatically, such that innocuous stimulus produce pain, and the duration and amplitude of its response to innocuous stimulus are amplified. While most patients do not develop neuropathic pain after nerve injury, and although only a handful of generic polymorphisms have been identified that confer area on enhanced susceptibility to development of neuropathic pain. This nevertheless clear that genotype is a substantial contributor of this nociceptive pain. Here we can see the deconstruction, the neuropathic pain phenotype to reveal the neural mechanism dysfunction. We have two different pictures. One is the burning pain, paresthesias, minimal mechanical allodynia, and thermal hyperalgesia and numbness. These are produced by the sensory terminal differentiation in the skin, no central sensitization, atrophy together with ectopic activity in head nociceptor. This is the alterations to produce this clinical picture. By definition, neuropathic pain involves damage to the nervous system. Often, negative symptoms are the first indication of damage to the somatosensory system, and would like to remark that can be detected by quantitative sensory testing and history questionnaire. The cause of negative symptoms in peripheral neuropathy is direct insult to primary sensory nerves. This produces cell-based or compromised transduction or conduction or transmission of sensory information. Loss of function can manifest across the whole sensory spectrum, or it can affect a specific modality. For example, an elevated head threshold due to degeneration of intraepithelial C fibers is a common early manifestation of peripheral diabetic neuropathy. This slide shows the next characteristic phenotype of diabetic polyneuropathy, painful, that reflect the mechanism of that. Here you can see it's different because it's a burning pain, the clinical picture, with spontaneous mechanical allodynia and minimal negative symptoms, not reduced thermal thresholds. This reflects the presence of relative reserve sensitized nociceptor in the skin, but with central sensitization. The major goal is to discriminate the pain phenotype, most robustly reflect different mechanisms or combination in this kind of patients. The next slide is to show the major pain factors of a phenotype. Neuropathic pain is very heterogeneous, with multiple patterns of presentation reflecting diverse combination of etiological, genetic, environmental factors, and specifically the neurobiological process they engage. Because of their mechanism diversity and different manifestation, this process produces a complex profile of constellation of positive or negative sensory symptoms and signs. So, we say the pain fingerprint. It is essential to shift focus to etiology, to the reaction of the nervous system to the etiological pathology, to view neuropathic pain as a manifestation of a pathological neural plasticity. The advantage of this approach is that it will lead to an explicit dual therapeutic focus of aiming to both an etiological factors and therefore maladaptive plasticity they initiate, and the symptomatic treatment of this alteration. There are several mechanisms to produce pain, not only one. In this slide, you can see spinal disinhibition. This spinal disinhibition is one of the cerebral mechanism. In this case, the excitatory nociceptive signals are enhanced after nerve injury by a reduction in normal inhibitory regulation through a loss of local inhibitory interneurons, a depolarized anion reversal potential, and reduce descending inhibition. The other is a change in the spinal cord that lead to a strengthening of synaptic input from both nociceptor and low threshold mechanoreceptors. Anti-nociceptive neurons contribute to an amplification of pain, with a reduction in its threshold and expansion in its spatial extent, and a change in its temporal characteristic. The recruitment of normally innocuous afferent input to the nociceptive pathway is an important aspect of central sensitization. And also, immune contribution to neuropathic pain. Innate and adaptive immune cells in the peripheral and spinal cord can sensitize primary nociceptor and secondary nociceptor neurons respectively to produce pain hypersensitivity. Finally, clinicians encounter neuropathic pain patients with a complex combination of neural pathological mechanisms, which is termed manifest as the individual pain phenotype. The pattern of expression of pain-related sensory abnormalities, the individual sensory phenotype, should reveal clues of the underlying pathophysiological dysfunction in this kind of alteration. Signs, one specific symptoms, burning pain, may be generated by several different underlying pathophysiological mechanisms. For example, peripheral sensitization, gain of function mutations in receptor, etc. Patients report outcomes, as well as quantitative sensory testing or a combination of both, are beginning to be used to analyze sensory profile in neuropathic pain patients and distinguish subgroup of patients who can be detected and characterized by different specific sensory profiles. The individual pain phenotype transforms diagnosis from the disease because we can understand mechanisms and we get a very good tool to make a treatment in the right direction and not for empirical treatment. This is my next question. Does the detection of phenotypes in diabetic foot neuropathy pain discriminate different mechanisms and or combination of this pain?
Okay, so please select the answer that you consider correct from the three options that you have. So about 67% detection of neuropathic pain phenotypes reflect the presence of relative preserved sensitization.
Excellent. This is the correct reply. Well, finally, I recommend these two articles to be able to assess more fully the diagnosis scope of QST and their application in daily clinical practice to get it the new diagnosis aspect of the phenotypes in this kind of patient with painful polyneuropathy diabetic patients. Well, thank you for your attention to my presentation.